So, hi students, I'm Dr. SJK. So, I'm going to discuss the INI-CET important topics with the relevant previously asked questions. This is going to be humdinger of a session for you people. So, you just have to focus, take notes of important topics, and as usual, I'll share the PDF of this particular discussion with you so that you could easily revise. Okay. So, straight away, I'll start the discussion. Shall I start? Shall I start the discussion? Yes. I receive no negative response, so I'll start. So first I'll start with this slide. INI-CET, previously called AIMS. So whatever exam comes, whatever the quality or amount of question varies. For example, NEET has been changed to next. NEET will have only 200 questions. Next will have numerous questions. Okay, but whatever the number of questions it may be, but mostly the important topics will hold its place in any question paper that you take outrightly. So previously AIMS, now INI-CET, whatever exam it was, there are few topics where most of the questions has been asked. So instead of discussing you with the questions alone in a haphazard manner, rather I thought that I'm going to discuss few topics which had more number of questions that has been asked over the last 5 years, including INI-CET as well as AIMS paper. So these are the 6 trending topics. For example, over the last 5 years, around 40 questions has been asked from ENT. Out of those 40 questions, around 20 to 25 questions has been asked from these 6 topics alone. Okay, yes, you should believe me, because these topics are very high yield topics. So if you focus here, if you understand at this class itself, you don't have to worry. Okay, fine. Straight away, I'll start with the class. The first topic is middle ear surgical anatomy. So you people are very well aware of the anatomy of the middle ear. 6 walls are there, malleus, incus, stapes, muscles. Many structures are there. You are all familiar with that. But these people are repeatedly asking some image-based middle ear or mastoid air cell system picture. For example, you can start answering. Identify the structure marked as A here. Okay, identify the structure marked as A here. Can I get the answers? Can I get the answers? Come on, please answer. Yes, I'm expecting your answers, people. Yes, 2 of you have answered. Can I see more answers, please? Okay, so those who have answered, all of you have answered correctly. The answer is incus. Okay, so this kind of image or similar image was asked some 3 years back. Okay, 3 years back. So it was from an AIMS paper. See here, this is an endoscopic picture of middle ear. Once you go through the tympanic membrane, you will see the ossicles. In the ossicles, here the malleus will be over here. Okay, so malleus is not visualized here. Here it is a, see, this is the area of malleus. This is the area of incus. This is the area of incus. So this is the area of stapes. Okay, can you get some surgical orientation? So if you don't get, I will play you a video. Just go look at this stepidotomy demonstration video. This is a demonstration video of stepidotomy. Here we are going to visualize the ossicles. Then we are going to cut through the footplate of stapes. Then finally we are going to place a piston over here. You just look at this video, you will get some idea about how the ossicles are placed. When you are looking at the ossicles,
the ear canal skin is first incised before being lifted off the bone carefully.
Microscope surgery. Here we are lifting the tympanomeatal flap. See, the white structure that we are lifting is the annulus of the tympanic
Here, the
membrane.
eardrum is now
Once you
being lifted,
completely
exposing the
elevate
middle
the
ear space.
tympanic membrane, see, can you beautifully see the ossicles over there?
In order
Can
to
you beautifully
visualize
see the
this,
ossicles over there? See, this is the long process of incus
the
attaching
incus
to the
is
stapes
then
superficialis.
disconnected
This
from the stapes.
prominent projecting area is what we could see over here. Okay, so we don't have to learn about this surgery and all that. You could study later, already discussed and all. So for you to get a surgical anatomy orientation, I showed this video. See, this is nothing but our incus. This is nothing but our stapes. This, the malleus, is not visualized entirely over in this endoscopic picture. So this is malleus. So in this endoscopic image, you have to identify the incus. Okay, fine. So here, the lateral semicircular canal cannot be visualized. You just have to keep this in mind. This is viewing through the ear canal. See here, if this is the pinna, this is the ear canal. We are putting upon the endoscope through this structure and we are visualizing here. So in this area, you could see only the ossicles and some of the middle ear structures, not the lateral semicircular canal. Okay. Before going into that detail, we just have to discuss the shape of the ossicles and how to identify the ossicles. Because 1 year back, a similar question, identify the ossicle. Many of them answered malleus, but the correct answer was incus. Okay, so you should have clear surgical anatomical depiction of these ossicles so that you will never go wrong. Malleus, shape of hammer. Incus, shape of anvil. Stapes, shape of stirrup. See, this is a hammer. The important identification point is anterior process will be projected. Then you should look for the slender. Okay, this is very slender manubrium, otherwise called handle of malleus. Manubrium, otherwise called handle of malleus. Now you compare it with the incus. The incus looks like a podium where we will cut the head of animals. This is anvil. The podium shaped thing is anvil. So this, the head is projected like this. The body is very slender and long. So this is long process. Okay. Then this one is lenticular process. Okay. So malleus, you should look for anterior process, handle of malleus. Incus, you should look for lenticular process, long process. Stapes, you should look for stapes foot plate. That is very easy for you. The only confusion is between malleus and incus, that you should never go wrong. Clear? So we are clear with the ossicle anatomy of the middle ear. Now we can get back to another question which was asked 4 years back, AIMS question. See, which of the following marked arrow represent lateral semicircular canal during cortical mastectomy? Here, two problems are there. First, are you aware of what cortical mastectomy is all about? Second, if you are aware of cortical mastectomy, are you clearly aware of where the lateral semicircular canal is located? Okay, that's the two important questions that comes to your mind. Okay, so before going into that, can anyone answer this? So lateral semicircular canal is A, B, C, or D. Which structure is over here? Lateral semicircular canal is A, B, C, or D. Please answer, people. It's your time. So if you can't answer now, you will feel a bit low. You start answering. You start giving guesses. So am I saying B? Okay. C, I could see all sort of responses, A, B, or C. B. Okay. Okay. Fine. Okay. So this is an actual question that has been asked in the NAMES paper. First of all, this cortical mastectomy, modified radical mastectomy, you should be very, very clear in your mind. Okay. First, I'll demonstrate you the cortical mastectomy video. Then I'll come back to the nuances. Okay. See, you just pay attention. This is a case of left CSOM. I am doing left cortical mastoidectomy with tympanoplasty. Clear? So whenever you look upon any ear picture, you should just have to imagine in your mind, see, Papre, this is left-sided or right-sided. That is the first important step. So this picture, this patient is a left-sided CSOM patient. Okay. So this patient is having a perforation. I'm just going to freshen the margins of the perforation. I am just elevating the tympanomeatal flap. This is how we will elevate the tympanomeatal flap. See, I'm elevating tympanomeatal flap. So this tympanomeatal flap is the blood supply for the graft we are going to place over there. Can you see? We have completely elevated tympanomeatal flap. Now you could see the ossicles. See, that white one is the malleus. This one is the malleus. This one is the malleus. All right. So we have elevated till the handle of malleus. Once we are done with this, we have to go back. We have to put up, see, can you see the handle of malleus clearly? Can you see the handle of malleus clearly? See, this is the handle of malleus. Okay, fine. So this is the handle of malleus. Okay, now I'm going back. I'm making a post-auricular modified William-Weil incision. I am exposing the mastoid cortex. Once I expose the mastoid cortex, I am drilling in a triangular fashion. This triangular fashion is the McEwan's triangle. In this McEwan's triangle, I am drilling till I reach an area called, see, can you see the air cells over there? This is the mastoid antrum. You now look, this is a left-sided CSOM, left-sided cortical mastectomy. So it is located like this. Okay. So once I reach the mastoid antrum, I'll place the graft over the perforation and I reposition the tympanomeatal flap. Then I'll close the procedure. See, can you see that? I'm placing the graft over there. This is how this is done. Okay. So main difference that you have to identify is the video that I have shown is left-sided one. Okay. So in left-sided one, if you consider this as an ear canal, this as a posterior canal wall, this is an area where you get the mastoid antrum. So this is an area. Okay. Whereas this is a left side. Okay. This is a right side. Okay. Another easier clue, if they give like this, the one that is behind the premises of the ear canal, it is the attic area. This has crossed the premises of the ear canal. This is a tip of mastoid. Okay, basic difference, very simple. Just have to keep this in mind. See, just behind the premises of the posterior canal wall. Okay, you can just draw the McEwan's triangle, posterior canal wall, zygoma, and a triangle joining that. So this is an area of McEwan's triangle where you could see the mastoid antrum. So the option D over here is the mastoid antrum part. Or okay, mastoid antrum. Okay, the A over here. Okay, what is the A over here? For you to understand about the importance of this A, you have to look upon another surgical video. I'll show the surgical video for you. See, this is a surgical video of cochlear
hearing device to restore hearing to patients who have severe to profound hearing loss.
Cochlear implant with
the procedure begins by performing a mastoidectomy accomplished by removing the hollow bone behind the ear.
Just look at this video. They are demonstrating.
After making an incision and retracting the ear forward to expose the mastoid bone surface,
drilling of
the honeycomb partitions of the mastoid or the tympani nerve, which supplies sense of taste to the facial, which is responsible for facial movements.
Can you see a hole? See the round thing? Can you see here? This round thing is nothing but facial recess. This round.
The round window is where the implant will be inserted.
Through the facial recess, which is a window posteriorly, you could see the round window. Okay.
Once the round window is exposed, a well along with a channel are then drilled into the skull upon which the implant is seated. The electrode array is then inserted into the round window and gently threaded into the cochlea.
The electrodes are inserted successfully through the facial recess into the round window into the scalar table. This is how it's done. Okay, for giving better idea for you, I'm going to insert the image that we have taken now. See here in this image. Now say this is a left ear or right ear. This cochlear implant is done on left sided ear or right sided ear. Can anyone please answer? This is left ear or right ear? Can please answer? People over there, left ear. You are very clear. See, can you see here? This is the posterior canal wall. This is an area adjacent to the posterior canal wall. Again, I'm going to draw the line over the zygoma, line over the posterior triangle. This area, can you look at this particular area? This is the McEwen's triangle. Okay, but the one that is very inferior over here, see here, this area is the facial recess. Can you identify the difference between these two surgical landmarks? This is facial recess. This is McEwen's triangle. So this facial recess is for cochlear implant. This McEwen's triangle is for cortical mastoidectomy. All right. Now we'll get back to the question. See here. Now, can you clearly delineate the A over here is facial recess. The D over here is mastoid antrum. Okay. Clear? Fine. Now, the C over here is our lateral semicircular canal. So here, now I'll again give you an important clue. So here you could see the lateral semicircular canal over here. So this lateral semicircular canal, will act as a landmark for facial nerve and incus. Okay, so this is a very important surgical point. Okay, now what is, so are you clear with this facial recess? This facial recess is formed by cauda tympani nerve, facial nerve, and short process of incus. Short process of incus. So this is the facial recess which we are talking about. This is the facial recess we are talking about. Okay, so these are very, very high yield points. They are repeatedly asking in your exams. So they are not asking conventional questions, they are asking some deeper questions. Now it's a easy thing for you. This is a post-operative demonstration of cortical mastoidectomy. Okay, so this is a right side ear or left side ear? Right side ear or left side ear? Please answer. Please answer. Everyone, please answer. I have shown you both the images. Again, I'll show you. See here. The patient is like this. So this is a left-sided one. This is a right-sided one. Okay. This is a left-sided one. This is a right-sided one. Okay. So now which replica is present over here? The antrum is present over here. Okay. I'll give you a simple clue. If you are having a picture, you should watch for the mastoid antrum. Okay. If the mastoid antrum is at the 9 o'clock position, it is right side. If the mastoid antrum is at 3 o'clock position, it is left side. Can you understand? I'll get back to it. See, this is the right side. Okay. I am having the mastoid antrum at the 9 o'clock position. This is the left side. I am having antrum at the 3 o'clock position. This is the basic difference how you are going to identify. If you identify mastoid antrum, you can identify all the important structures. I'll get back to the question. I'll get back to this. See here. This is not the mastoid antrum. This is tip. This, can you see the short process of incus projecting from over here? So this side is so this is left side. Okay, this is left side. 3 o'clock push. Okay. Now these are all cortical mastectomy pictures where you are leaving the canal wall intact. This is intact canal wall mastectomy. Okay. Now, if you are going to sacrifice this posterior canal wall, it is called canal wall down mastectomy or modified radical mastectomy. This is called modified radical mastoidectomy, or otherwise called canal wall down mastoidectomy. Canal wall down mastoidectomy. Now, can you see here? This is nothing but the middle ear. This is nothing but the mastoid cavity. So we are joining these two cavities into a common cavity. So middle ear cavity, mastoid cavity is made into a common cavity by demolishing the posterior canal wall till the facial nerve, because the facial nerve runs parallel to the posterior canal wall. So we are not sacrificing the facial nerve, we are removing the posterior canal wall till the facial nerve. That's why this is called facial ridge. Okay, so you may think that, see, sir, this is the canal wall. No, this is not the canal wall. This is the facial nerve. Okay, so the canal wall is sacrificed till the level of facial nerve, not beyond that. Okay, this is a typical case of modified radical mastectomy. Here, no hearing reconstruction. Here, hearing reconstruction. Okay, so here the disease clearance is the main motto. Here, disease clearance plus hearing reconstruction. So the important thing is we will leave open the canal wall, eustachian tube opening. Leave the eustachian tube patent. Okay, leave the eustachian tube patent. Whereas if you do a radical mastectomy, you are closing the eustachian tube. Okay, so we have learned about the important cortical mastectomy, modified radical mastectomy. All are very, very high yield topics. You should be very clear with these topics. Okay, so some of the important one-liners: when you are doing an endolymphatic sac decompression surgery in Meniere's disease, So the line that is drawn, the line that is drawn at the base of the horizontal semicircular canal, that will bisect the posterior semicircular canal into two, will act as a landmark for endolymphatic sac identification. What is the name of this line? Can anyone please answer? People, please answer. A line that is drawn from the base of the horizontal semicircular canal that will bisect the posterior semicircular canal. It helps in identifying the endolymphatic sac, that will be helpful in endolymphatic sac decompression, venous disease. Dr. Pavitra, you are spot on. The line is called Donaldson line. Line is called Donaldson line. Dr. Pavitra, Dr. Vidya, you are spot on. You are great going people. Keep it up. Again, this is a picture of McEwen's triangle where we are identifying masted antrum from external appearance itself. Okay, so very high yield topic you would have not learned of. Okay, again a different topic they are repeatedly asking in the exams. 3-4 questions has been asked over the last 3-4 years. Subjective diagnosis of the year. So out of subjective diagnosis of the year, mainly I'm going to cover 2 topics: tuning fork test, audiometry. Okay, first we'll start with a question about AIMS 2019 question. A 35 years female presented with hearing loss with improvement in hearing in noisy environment. RINA is negative, VBOS centralized. Following is the audiometry. What is the most likely diagnosis? Answer, please answer. Please answer. What is the answer for this particular question? It's a typical audiometry appearance. It's a typical audiometry appearance of bone conduction. It's a typical audiometry appearance of bone conduction. Please answer. Otosclerosis. Yes, Dr. Mohanraj, you are correct. Dr. Vidya, you are correct. All of you are correct. Okay. See here, we have numerous points for us to diagnose it as otosclerosis. Point number 1, she is a female patient. Point number 2, the age is 35. Then hearing loss with improvement in hearing in noisy environment. What it is called as? It's open for all. The phenomenon is called as hearing which improves in noisy environment. Then RINA is negative, we was centralized or lateralized too. Okay, I'll tell Vidya. I'll tell once I complete this question. You please answer. What is this phenomenon called? Hearing loss with improvement in hearing in noisy environment. Anyone? Okay. Since this RINA is negative and VBOS centralized. Okay, RINA is negative, VBOS centralized. Okay. Okay, fine. Dr. Vidya, you are spot on with your answer. The phenomenon that has been quoted here is paracusis willisii. Okay, paracusis willisii. Okay, so normally they will not hear better. In the presence of noisy environment, they will hear better. This is called paracusis. It's like a paradoxical activity. So paracusis willisii. So here they are code. So okay. Again, we'll get back to the audiogram and tuning fork test and we'll solve this MCQ because very high. So we have to discuss again and again. Sensory neural hearing loss, conductive hearing loss, mixed hearing loss. I have told you 3 thumb rules. Thumb rule number 1 is look for the graph, any graph more than 25 decibel. Thumb rule number 2 is look for bone conduction. If bone conduction is normal, no SNHL. The bone conduction is more than 25 decibel. It is yes, SNHL. Then R bone gap. more than 10 decibel or less than 10 decibel. More than 10 decibel airborne gap, conductive hearing loss. Less than 10 decibel airborne gap, sensory neural hearing loss. So these three thumb rules you should never forget, people. So with these we could answer any sort of questions. Okay, first we'll start with this 0, 10, 20 is there. This is the normal hearing range. Within 25 it is normal. Thumb rule number 1, whether the patient is having hearing loss or not. Okay, here more than 25 decibel, both the curves are present, so definitely hearing loss is present. Thumb rule number 1 satisfied. Thumb rule number 2, you look for the broken lines. I have already told you, broken lines for bone conduction, continuous lines for air conduction. Okay, so continuous lines for air conduction. Clear? Now you look upon both the curves are more than 25 decibel. So here there should be definitely sensory neural hearing losses present. Thumb rule number 3, airborne gap. See, we are having two curves over here. The broken lines and continuous lines are superimposed with each other. Broken lines and continuous lines superimposed with each other. This phenomenon is airborne gap less than 10 decibel. So this is a pure sensory neural hearing loss. Okay, now we'll get back to the next picture. We'll draw the diagram of 25 decibel. One curve is more than 25 decibel, so hearing loss is present. Now you look, this is the bone conduction curve. So this bone conduction curve is less than 25 decibel. Thumb rule number 2. Okay, so no SNHL. Thumb rule number 3 is airborne gap. See, look at the gap between these two curves. Airborne gap more than 10 decibel. So as airborne gap more than 10 decibel, we are having a pure conductive hearing loss. All right. Now, third picture, thumb rule number 1, both the curves are more than 25 decibel. Thumb rule number 2, we are having bone conduction at the abnormal level. Then airborne gap is more than 10 decibel. So this is a case where there is both conductive loss and sensory loss is present. If we apply the formula of 3 thumb rules, we could easily arrive at the diagnosis with the audiogram image. So we'll get back to the question. This audiogram is nothing. This audiogram, right side or left side? Conductive loss or sensory loss or mixed loss? Please answer. This is a case of, so blue color for left. Okay, red color for right. Number 1. Now we will apply the thumb rules. Please answer. Please answer. So it is left-sided, conductive loss, sensory loss, mixed loss. What? Conductive left. Mohan Raj, you are correct. Please others answer. See here, we are applying 3 thumb rules. Thumb rule number 1, any of the curves more than 25 decibel? Yes, satisfied. Thumb rule number 2, the bone conduction is normal, so no SNHL. Thumb rule number 3, airborne gap more than 10 decibel. So only conductive hearing loss. Okay, pa? Are you clear with this explanation? So this is a clear-cut picture of left-sided conductive hearing loss. So with the audiogram, we are having a diagnosis as left-sided conductive hearing loss. With it is confirmed with tuning fork test. Okay, tuning fork test. Again, I'll teach you. See, tuning fork test. Rinne negative means conductive hearing loss. Airborne gap, ABC and SUBA test, if it is shortened or reduced means it is SNHL. You keep it like this. Rinne, it is mainly for conductive loss. Absolute bone conduction, SUBA mainly for sensory loss. Weber's is the best test where you could diagnose both the loss perfectly. So conductive loss lateralized to the affected ear or poor ear. Sensory loss lateralized to the better ear. This is the main thing you should never forget. See that you are keeping in the middle of the forehead. It is lateralized to the affected ear, conductive loss. Lateralized to the better ear, sensory loss. Affected ear, conductive loss. Better ear, sensory loss. Affected ear, conductive loss. Better ear, sensory loss. Never forget. Okay. Now again we have to apply. See, Rinne is negative. VBUS is centralized. It is not lateralized, which means that the patient will be having both the ears as deaf, because otosclerosis is a condition which occurs bilaterally. Okay, so as it occurs bilaterally, both the ears are having almost similar hearing loss. The VBUS is centralized. Okay, so no wrong in that. But Rinne is negative. As Rinne is negative, this patient is having conductive hearing loss. Out of these 4 options, Meniere's disease is only SNHL. Perilymphatic fistula is postural SNHL. I have discussed in the INI-CET distant discussion. Postural SNHL. Supine position, you will get fistula leakage, so that SNHL will be present. Upright posture, no leakage, no SNHL. Vestibular schwannoma, very, very important benign tumor of the inner ear, is again SNHL. So out of all these options, with the audiogram, if you diagnose it as conductive hearing loss with the audiogram itself, you could easily tell this question to be stapedial otosclerosis. So what is the stapedial otosclerosis? What are the other types of otosclerosis? See, cochlear otosclerosis, a type which can cause SNHL. Okay, cochlear otosclerosis is a type which can cause SNHL. Okay, so stapedial otosclerosis is most common. If they give in the question as plainly otosclerosis, they are defining or indirectly meaning it is stapedial. So cochlear is very, very rare. So in the question, if they give only otosclerosis, at that time you don't confuse yourself whether it is stapedial or cochlear. Never. If at all they give otosclerosis, means it should be stapedial, not cochlear. But in this question, they have given clearly a stapedial otosclerosis. This is the answer for this particular question. Clear? Okay. So we're done with one question just been asked at AIMS 2019. Another question related to tuning folk test. Jelly's test is being done in. Jelly's test is done in otosclerosis again. Okay. So it is a special tuning folk test. Normal people, you place it over the mastod area. You occlude the tragus. The patient will say that the sensitivity I'm hearing is reduced. Okay. Whereas in otosclerosis, the sound sensitivity will not reduce, or else it will be maintained same. That is the difference between otosclerosis patient or normal patient. I'll repeat it again. This is the ear canal. This is the tympanic membrane. We are going to introduce the pneumatic speculum. This pneumatic speculum will increase the pressure of the ear canal. Okay. Once you increase the pressure, you place the tuning fork behind the mastoid area. If you are normal, the patient says that previously I had some vibration, that intensity has reduced once you place the Siegel speculum into the canal, which means that the increased pressure will push the tympanic membrane inwards, will push the stapes foot plate inwards. The inward movement of the stapes foot plate will reduce the sound sensitivity. The inward movement of the stapes foot plate will reduce the sound sensitivity. Whereas in otosclerosis, there is stapes fixation. There is stapes fixation. So there is no inward movement. No inward movement. No inward, because stapes has been fixed due to sclerotic bone. Stapes foot plate is fixed due to sclerotic bone. So no inward movement. So in that case, Jelly's test is positive only in otosclerosis. In normal patient, the sound will reduce. Otosclerosis patient, the sound will maintain normally or same as before. Okay. So tuning folk test has been done. Clear? Fine. So spot diagnosis. What is the curve? Anyone please answer? This curve is? Please answer. So this is not a carrot snatch that we have seen in. See, this question again has a carrot snatch. Okay. This 2000 Hertz dip in the bone conduction is carrot snatch. Okay. Whereas here, the dip is at both the bone conduction and air conduction. Dr. Mohan, you are correct. Anyone please answer? Any others? 4000 Hertz See, 4000 hertz dip, both air conduction and bone conduction. Anyone, please answer, please answer. People, this question is for you. What is this curve called? What is the diagnosis for this particular audiogram? Yes, it is your spot on. Noise induced hearing loss or acoustic dip. Clear, pa? Yes. Noise induced hearing loss. Okay. This is again a diagnosis of carrot snatch. Now, can anyone answer this? This audiogram? Some downsloping and upsloping audiogram. What is the diagnosis? Some downsloping and upsloping audiogram. What is the diagnosis? Please answer. Congenital deafness is the correct answer. Okay. So this is cookie bite pattern. Okay, key bite pattern of audiogram seen in congenital deafness. You people are great, great, great. So we'll finish the subjective diagnosis topic with this question which we previously discussed. 50 years female, present with hard of hearing, and she has following audiogram. What will be the Rinne and Weber's answer? So in this picture, right side is normal. You just look at the left side. What is there? So if left side, you first, with the help of the audiogram, come to the diagnosis. With the diagnosis, you apply tuning focus to the diagnosis. Rinne, what will happen in that particular diagnosis? Weber's, what will happen to Weber's in that particular diagnosis? So you just have to derive the diagnosis and then apply Rinne and Weber inference to that diagnosis. So with this much practice, you should do this instantly. Okay, that's why I have been repeatedly saying this. Okay, so anyone please answer? I could see no answers. Please, people out there, answers, people. The answer is yes, Dr. Mohan Raj, Dr. Mohan Ram, we both are excellent. See here, see, this is a conductive hearing loss of left side. So left side, Rinne will be negative, right side Rinne will be positive. Weber's lateralized to the affected ear. So this is the affected ear. So the inference should be either Rinne, left Rinne negative, Weber's lateralized to left, or right Rinne positive, Weber lateralized to left. Either two, you should look for these two options. The answer is C. Okay. See, why I am telling this repeatedly, because you should not waste 5 minutes for this particular question. You should spontaneously do that. Audiogram, right, left, 3 thumb rules. I have a diagnosis, then apply Rinne mainly for conductive, Weber's for both conductive and sensory loss. ABC Schwabach, if at all given, it is mainly for sensory loss. So these are all you should be in fingertips so that you could save the time in this particular question. Clear? Now we move on to the nose discussion. Epistaxis is it's a highly attractive topic for the AIMS and INI-CET people. They are asking repeated questions from epistaxis. So first we'll start with this question: which of the following is not a branch of external carotid artery in case of ADrPLEXUS? INI-CET 2020, AIMS 2019. Both the times has been asked. The answer is, please answer, pa. The answer is A. Okay. So let's quickly brush through the branches. See, we are having anterior and posterior ethmoidal arteries. These are branch of ophthalmic artery, which is a branch of ICA, internal carotid artery. Whereas sphenopalatine artery, irritable artery, both are branches of maxillary artery. Okay. Superior labial artery, It's a branch of facial artery. So maxillary artery and facial artery finally end up in the external